Hi there, I'm Lucy McDonald, physiotherapist. Welcome back to my virtual clinic. Today I have a really special guest that I'm very excited about introducing you to. This is Ian McDermott, consultant orthopaedic surgeon, specialism in knees at London Sports Orthopaedics. So today Ian is going to talk all about meniscus or menisci as the plural goes. And he's going to talk about how you can tell if you've got a meniscal injury or problem, what you can do about it, what the non-surgical options are, and ultimately what's the latest research on surgery for meniscal injuries. So, Ian, is there anything else that you'd like to add? Because I slightly stumbled through that introduction there.
No, that's perfectly fine. Thank you, Lucy. I'm a consultant knee surgeon, do nothing but knees. Very, very into meniscal research, meniscal surgery, meniscal replacement. So more than happy to talk about any aspect of this anytime.
And I just have to warn the viewers that I may have to interrupt Ian throughout this, because if there is something about Ian that I know, he is so passionate about knees. What there isn't to know about knees isn't worth knowing. And I know that Ian could talk for hours and hours about menisci. So in advance, apologies if I interrupt you, Ian, because I know how passionate you are on the subject and incredibly knowledgeable. So I personally could listen to you for hours as well. So yeah. Let's commence then. So probably a good start, Ian, would be to establish what are menisci?
So inside each knee, inside your knee, you have got two little C-shaped elastic cartilage wedges, a little bit like the outer part of your ear. So C-shaped, springy, elastic. On the model, they're blue, if you can see what Lucy's holding there. So one on the inside is called the medial meniscus, one on the outside is the lateral meniscus. And they sit between the femur and the tibia, and they act as load sharers and shock absorbers. They're probably one of the most, if not the most common thing that gets damaged inside a knee joint. So we see meniscal tears on a very, very regular basis.
Yeah, absolutely. And how can our viewers know whether it is a meniscal injury that they've got, there's a problem with their meniscus?
So there's two ways that you can injure a meniscus, or that a meniscus can be damaged or torn. The first is in younger people who've got a healthy meniscus that's otherwise normal. It wouldn't normally be expected to tear unless there's some kind of specific trauma. And that's normally from an accident like twisting on a bent knee. So a football tackle, a ski injury, but something fairly major. The other kind of tear is when you develop a spontaneous tear in an older person who's got a degenerate meniscus. And 50% of degenerate meniscal tears occur spontaneously with no history of any trauma at all, which sounds a bit odd. But if you think of the meniscus like that rubber washer, well, if you have a tap in a room that you haven't touched, you haven't touched it for ages, and all of a sudden the tap starts leaking, and you think, well, why is it leaking now? Well, the simple answer is that the rubber washer's perished, and it's a little bit like that in a knee joint. So as you get older, the meniscal cartilage, like a rubber washer, can perish, which means it becomes degenerate, which means it has a poorer blood supply. The tissue becomes softer, more friable, more liable to tear, and therefore it can tear with minor or minimal trauma, even just the forces of daily activity. So 50% of degenerate meniscal tears occur spontaneously. So there's a big difference between the two, even though the distinction, there's a bit of a grey zone, because people don't just suddenly get old, you gradually get older. But generally speaking, the way we approach a traumatic tear and a traumatic meniscal tear in a younger person versus a spontaneous degenerative tear in an older person is somewhat different.
Okay. Are there any similarities of where they might be feeling the pain?
Yeah, no, it's you have to be a little bit careful with this, because in some people they present with a classic meniscal tear and they'll say, I've got pain on the inner side of my knee. They can pinpoint it, they can touch it with their finger, they say it's exactly here. And that often tends to be a sudden sharp pain, particularly if you load the knee in flexion, so if you load the knee when it's bent, or if you twist on the joint. And they may complain
like squatting, that sort of thing in.
Yeah,
Yeah,
particularly
sorry, a bit of translation.
Yeah. So if
I
you're
know what load bearing
squatting,
flexion is, but I'm not sure everyone knows what load bearing flexion is.
everybody does. Oh, everybody does. They will soon. So
Exactly.
I think if you've got a meniscal tear, the worst thing that you can do, the thing that hurts most, is to kneel on the floor and try and sit back on your heels so your bottom's resting on your heels. And that's when you really squeeze the back of the meniscus, and that can cause pain around the back of the knee. So pain at the back of the knee with deep bending, that's often a sign of a tear in what we call the posterior horn, the back part of the meniscus. Also, if you tear a meniscus, then quite often you tend to get swelling in the joint. You may get painful clicking. Clicking without pain is not that interesting because everybody's joints click. If you click your fingers, it doesn't mean you've got torn knuckles. But painful clicking that wasn't there before, that's relevant. Also, if the patient gets giving way, and by giving way, what we mean is you put weight on your knee and it just goes, you feel like you're going to fall, you suddenly lose control of the leg. Or locking, and locking is probably the cardinal sign that we look out for, and that's where you try and straighten your knee and you can't, it gets stuck, so you can't fully straighten it. Temporary locking is where it's stuck, you give it a bit of a wiggle, and then there's a clunk and it straightens. But if somebody presents with a locked knee, which means it's fixed and they can't straighten it, then that's a relative urgent for us, and that's much more serious. So those are the kind of symptoms to look out for.
So just to absolutely clarify on that one, Ian, that if someone is unable to fully straighten their knee, that they need to contact their doctor immediately.
Yeah, there's two different categories for unable to straighten your knee. The first category is that you're developing what we call a fixed flexion. And what that means is that you've probably got an arthritic knee. And as you develop wear and tear, degeneration and arthritis in a joint, then the joint becomes painful, stiff and swollen. And you begin to lose your range of motion. And one of the things you lose is the ability to fully extend. So the knee gradually becomes slightly bent. So if you've got a knee that's painful, swollen, slightly bent, and it's been gradually developing or gradually going that way over a period of time, and we're talking not weeks or days, we're talking months or years, well, that's a fixed flexion. That's not what we're talking about. What we're talking about is a locked knee. And a locked knee is a knee that used to go fully straight, then something happened, there was trauma, there was an episode, you felt something go pop or ping, sudden pain in the knee, and then it swelled. And from that point onwards, you've not been able to straighten the knee fully. It's not about not bending it, not being able to bend the knee fully is much more, as I say, much more non-specific. But if you can't extend, you can't straighten the knee fully after an episode, whereas prior to the episode you could, well, then you've got a locked knee. And if you've got a locked knee, then you've got something that's called a locked displaced bucket handle tear of your meniscus until proven otherwise. And by that, what we mean is that you've got a big tear of the meniscus with a displaced bit of tissue that's flipped over and it's stuck in the joint and it's trapped, preventing you from straightening. In that situation, it's not an emergency. With us, an emergency means that you have to be admitted from clinic that day, straight away, and you're probably going to be operated on that evening. Right? That's life and limb threatening stuff. So it's not in that category. It's in one step down, which is the urgent category, which means you need an MRI scan, ideally within a few days, not weeks, days. And if you have got a displaced locked bucket handle meniscal tear with a locked knee, particularly if you're younger rather than older, then you need surgery, and you need surgery within ideally a number of days, not weeks. If you catch that kind of meniscal tear within the first 6 weeks, then there's a decent chance you might be able to flip the tissue back into place before it's too badly damaged, stitch it and repair it, and therefore salvage the meniscus. If you leave the knee more than about 6 weeks, which is a very arbitrary cutoff, but let's say 6, the longer you leave it, the less likely it is to be reducible and repairable. And if it's not, then the only way you're going to be able to get that knee going straight again is to go in there and take the meniscus out instead of repairing it. And if you lose the meniscus, then you've lost the shock absorber, which then significantly increases the risk of arthritis in that side of the knee in the longer term future. So that's why it's, for us, it's an urgent.
And I think it's really important to empower people with this information, because unfortunately a lot of GPs wouldn't necessarily be aware of that. So I think anyone who's watching this is is now empowered to sort of go and explain to their GP, look, this is what I'm concerned about, and then the GP can respond accordingly. So
I had a recent case just literally 1 or 2 weeks ago of a person in their early 30s with a locked knee who'd been told by their GP, go away, build up the muscles, go and exercise, build up the muscles. Once you've got your muscle strength back, then if there's a problem, we'll have a look, which is frankly stupid.
Exactly.
It's the opposite of what's needed.
So you and I know why that's frankly stupid, but the reason that that's stupid is that if you can't fully straighten your knee, you can't contract the muscles through that range, and therefore it is literally impossible to strengthen your knee. Never mind all the other stuff that Ian's mentioned, that you lose a huge amount of very essential, that range of motion that's so important for day-to-day functional activities like walking. You're going to lose all that strength and then get secondary issues as a result. So yeah.
I mean, on top of that as well, even if you were able to build up muscle strength, which Lucy's right, you absolutely couldn't. Even if you could, it's the last thing you want to do. The last thing you want to do is load and exercise a joint with damaged tissue in it, where you're simply going to make the damage worse.
So the things to look out for, not to, obviously it's broader than this, but just to try and give some kind of simple guidance, particularly if there's pain over the inside of the knee. And I remember you once, many moons ago actually, I was going to say a few years, but it's probably a bit longer than a few years. I remember you saying, I don't know if you still stand by this, but you said that how to differentiate between the medial but anyway, so we're just looking at the ones down here. I remember you saying, if the patient says this, and the patient says this, then it's like the MDL, lateral. So I don't know if you remember saying, or if you still educated for that one.
Yeah, I do remember. The reason I'm smiling is because now you've really caught me out, because I am completely dressed COVID style for a Zoom meeting. And so, because it's a nice sunny day,
so let's move on.
Very cheekily, I'm wearing shorts. Bad news is that doesn't look very professional. Good news is you can actually see my knee. So here's a knee joint that I prepared earlier, and if you look at the knee, if you have pain here on the inner side of the knee, so round here, then you're thinking, yes, it might be the medial meniscus. If it's pain here, it might be the lateral meniscus. If it's pain on the side going up and down, then yeah, you might have strained, very stiff, very bad back. You might have strained your medial collateral ligament. The important thing is
or a bit of both.
Or both. The most important thing is, you listen to your body. You know if you've done something serious. If you've done something minor and you've got a minor ache or a tweak, then fine. There's not so much urgency. If you just have that feeling, I've done something and I've done something significant, then don't wait, get it checked out. Go and see a decent physio, or go and see a knee surgeon, or go and see the physio and then the knee surgeon, but go and get checked out. And if there's any suspicion at all about anything of significance, you're going to need an MRI scan. Right? MRI scan is invaluable. When you look at somebody's knee, you're looking at the skin. Right? You're not looking inside the joint. We don't have X-ray vision. And even X-ray vision would be rubbish, because when you do an X-ray, all you can see is the bones. If you want to see what's really going on inside the knee in terms of the bone, the ligaments, the cartilage, the meniscus, everything, then you need an MRI scan. Now, some people say that we do too many MRI scans. Well, I can understand why they might say that, because they're right in as much as you don't treat the scan, you don't treat the picture, you treat the patient, because there's a lot of false positives on an MRI. You may see something that isn't actually of any clinical or practical relevance, but that's not a reason not to do an MRI scan. So the best analogy I can give for that is an MRI scan is like your eyes. You're looking. Whereas taking a clinical history and examining somebody is like your ears. Well, you wouldn't cross a road with your eyes shut, just listening, on the expectation that you can hear a car coming. And if it sounds like there's no car, then you're probably safe to cross. Well, you'll be fine until somebody in a Tesla comes along, and then you're going to get splatted. Mm. So if you've got eyes, you're going to look. So if you've got an MRI, and we've all got access to MRI scans, and you can get a very good quality, cheap MRI for as little as £250 within literally just days from places like Vista Diagnostics or Leica Health in Canary Wharf, or Orion Health in near Harley Street. You can get an MRI scan very quickly for £250 or so, and that's within most people's budgets. And if you get an MRI scan, and if it's normal, well, great, panic over. But if there is something going on, then you really need a diagnosis. And you won't get a proper, thorough diagnosis until you've actually looked on the inside of the knee. And the best way to do that with zero risk, because it's non-interventional, is an MRI scan.
Yeah, absolutely. And I think as a physio, this is something that it's an absolute joy working with an experienced and principled surgeon as yourself, Ian, because unfortunately I've seen situations where patients have had MRIs, and there's always a lot, radiologists particularly love very detailed reports, and that's great, but it's all about the interpretation, as you say. And then the trouble is that those MRIs are sometimes used in their entirety to justify in what may have been unnecessary surgery. And I think that's, for me, what's so fabulous about, when you see a patient, you will only do surgery as a last resort, because that is, well, or not as a last resort, as when you have clinically reasoned
when it's needed.
But unfortunately, there are those out there who perhaps, with lack of experience, maybe, I don't know, will just go in and do surgery on any old knee, which isn't necessarily the case. That isn't what you would do. So that's very reassuring from my perspective as well, as a physio. So that's awesome. So I guess I was going to ask you sort of how you would advise patients to manage their surgery, but that's what I might do, is do that in a separate video, Ian, because I'm sure what people really want to hear from you is from a surgical perspective, if someone has had their physio and we just don't feel that they're progressing, or as you say, they've got a bucket handle tear that needs attention, what are their options surgery wise? What at the moment would you say are the best options for patients, and what are the things that they might want to avoid as well?
Gosh, best thing you can do is go and see somebody.
I know that you could talk about this for the entire day.
That's what I was thinking. How can I cut that one down?
I know that's why you're going to be like,
big question. I would say your top priority is to go and see somebody who's a specialist knee surgeon, not somebody who's a generalist. Go and see somebody who is specifically recommended to you by somebody you trust. There are, just like there's dodgy builders out there, or dodgy mechanics where you take your car and they'll go, oh yeah, you definitely need a new engine, all right? And all you need is an oil change. Sadly, doctors are human beings, and there are nice doctors, not so nice doctors, nice surgeons, not so nice surgeons. But they're really importantly, you go and see somebody you trust. Go and see somebody who you can trust to give you a safe opinion. Just because you go and see a surgeon, it does not mean you are going to have surgery. You're going to a surgeon for an opinion. I only operate on about 25% of the people that I see in clinic. That means 75% of the people I see don't need surgery or don't want surgery. But what everybody needs and absolutely must have is a clear and specific diagnosis and a clear and specific management plan, which may well be non-operative. So I think the best advice you can get is get seen quick. Don't sit on things and wait. Right? Get seen quick. Go and see a physio that you know is good. Go and see somebody you trust. If there's any suspicion of anything serious, go and get an MRI scan. Never, as a patient, read the MRI report.
Yeah.
because it will be full of misleading and worrisome information that may not be of any practical relevance at all. It's not about the picture, it's about interpretation of the picture and picking out what's relevant to the individual. Get a proper opinion from somebody who's a trustworthy conservative surgeon, not somebody who's trigger happy on a scalpel.
And we're not talking about political beliefs when we say conservative. We mean, you know,
with a small c,
less likely to do surgery.
Yeah. Well, yeah, I don't know many surgeons who are not capital C conservative, and that's half the audience gone. And if you need surgery, then get it done by the best person you can and don't hang around. However, understand that literally a majority of the things that we see in clinic do not need surgery. It all depends on what the diagnosis is, who the patient is, how their symptoms are affecting them. It's multifactorial.
And then if you do decide that they need surgery, what are the things that what are the options there?
Right. So if you've got a meniscal tear, and if it's bad enough to justify surgery, then you're going to need an arthroscopy, which is keyhole surgery. You put a little telescope into the knee and a little probe through 2 little 5mm incisions, so it's minimally invasive. Operation can take anything from 30 minutes up to an hour or so. It depends on what you actually what you find and what you do. If you find a meniscal tear, then you've only got 2 options. It's either repairable or not. If it's repairable, you're going to stitch it back together. And if you stitch a meniscus back together, and if you pick and choose your repairs appropriately, then the success rate is roughly 90%. If it heals, it means you've kept that meniscus. If the meniscal tear is not repairable, then what you're going to do is you're going to trim the torn tissue to get it smooth and stable, to get rid of the symptoms, because the meniscus has got nerve fibers in it. So if you trim the torn tissue, you get rid of the symptoms. The bigger the tear, and the more damaged the meniscus is, and the more tissue you have to trim, then the less of a shock absorber will be left in the knee, and the bigger the risk of arthritis in the future. That's why, if you've only got minor symptoms and they're manageable, you're better off leaving it alone. But if your symptoms are too bad in terms of pain and restriction of function, and you need to get something done, then you might need to have your meniscus trimmed. And if we trim a meniscus, we take away as much as is necessary to get the remaining tissue smooth and stable, to get rid of the symptoms, whilst at the same time leaving behind, or trying to leave behind, as much as possible.
Great, that's really helpful. I'm going to ask one slightly cheeky question, because I didn't say that I was going to cover this, but I see a lot of runners, and particularly at the moment, and hopefully, you know, the London Marathon is going to be going ahead. But I wanted to ask, a very common question with runners is, can I carry on running if I've got a meniscal injury? Yeah,
it's a daft question, because it's the wrong question. It's not can I. It's not can I run, it's should I run. And I would throw this back to you. Let's say I was a respiratory physician, and let's say you come to see me because you can't breathe properly and you're coughing stuff up because you've got bronchitis or chronic bronchitis or emphysema from years of smoking. And you walk into my clinic and you say, can I continue smoking? Well, the correct answer to that question is an emphatic yes, you can.
Yeah,
the correct question is, should you continue running? And the answer is, only if you're stupid.
Okay, I think that is
a number of people who come into clinic and say, my knee hurts when I run. What do you think I'm going to say?
I would have thought it would.
Doctor, it hurts when I do this. But don't do that.
I know you very well, Ian, and I know that your answer would not be that simple. I know that you would look at the patient, everything that was going on, and all the rest of it. But yes, I think we will appreciate where you're coming from on that one. So yeah, that was nice and clear.
Good. So now that means that nobody with a running injury is ever going to come and see me. That's great.
No, but I know also that you do see a lot of high-level sports.
Oh, loads.
And
yeah,
you're very comfortable with managing those people. But yeah, with a sense of humour as well, which is always good, and a bit of hard truth in there as well. So really helpful. Okay, so is there anything else that you'd like to add in, or shall we wrap up? I think we've gone on for a bit longer than we planned, but there's
It's
no
only like
pressure.
maybe just a 30-second plug for a procedure called meniscal transplantation, because most people don't seem to know about it. So if you've lost your meniscus, if you've lost your shock absorber because it's been torn, it's been damaged, you've had to have it trimmed or removed, and if you do then start to develop early symptoms and signs of wear and tear, and it's not too late, you haven't developed fully blown arthritis, then you can actually replace a missing meniscus with a donor meniscus, and that's called meniscal transplantation. And that's got quite good outcomes, 80 to 85% success rate at 5-year follow-up. So just so people are aware, you can actually replace a missing meniscus. There's only a small number of us in the UK who actually do that. There's only a tiny handful of knee surgeons who do that specialist procedure, but it is available and it is possible.
Great. I will put your contact details in the comments section at the bottom here. So if you would like to contact Ian, please do just check out those there, and likewise my details as well. So Octopus Clinic website is the place for you. So I think we're going to wrap up there, and I'd like to say a very, very massive thank you and a big cheer. Thank you so much for joining me. It's been an absolute pleasure. And please do know what you'd like to do next. Press that subscribe key, and in the meantime, take care. Bye everyone. Bye Ian.